So obviously cardiovascular system, heart, blood, whole system, peripheral, out into the extremities and so forth, and then the lungs. We've got arteries. So we go here for our carotid. Goes down, it's going to go further into arterioles, which go to capillaries, which connect to venules and then veins. So again, big system here. Capillaries, where everything happens. I read something the other day that said that there is no cell in our body. This is amazing if you think of it. No cell within our body that is more than 0.5 millimeters from a capillary. Not one cell in your body. So again, blood flow. That's how everything happens and how everything heals in our realm of things. Nutrient exchange, obviously. Oh, there's the thing, 0.1. I was saying 0.5, it's 0.1 millimeters. So again, capillaries exist throughout. You've got to have that blood flow. Structure. I'm not going to have you recite this, but you probably should know for the most part. It's going to come in here from the vena cava and the inferior vena cava. This is going to go to where? Right atrium. So let's go through the tricuspid, the right ventricle pumps out through the pulmonary artery, left and right to each lung, okay? Then comes back through our system via the, not all at once, pulmonary vein, back into the left atrium, left ventricle, pumps out through the aorta, and there we go. So again, lots of things going on here. Which side's the stronger side of the heart?
Left atrium?
Left ventricle. Look at the wall here, how thick this is, because this is what it's got to pump that all the way out through the aorta. Review if you don't remember. Cardiac cycle. Systole, when the heart is contracting. Diastole is when it's relaxed. Okay? You've got coronary arteries on the outside of the heart. Does this depict any of those? This one does. All of these arteries need to be able to flow blood to keep the heart active and healthy. Okay, if you get a blockage here on one of these, part of that heart's going to die off. What is that called? Myocardial infarction. Heart attack. Correct. Cardiac muscle gets majority of blood during diastole when it's relaxed, because it pumps and the blood gets to it. Okay. An adaptation to aerobic or cardiovascular training, the slowing of the heart rate during rest, because your heart's more efficient, okay? And it will be less during submaximal exercise. You still have the capability of really pumping it up if you need it. Posterior view, anterior view. The heart has autorhythmicity, something like that. It can generate its own impulse through the SA and the AV nodes. It's an electrical circuit. Again, we could talk all we want about the electrical part and so forth, the physiology behind all this. We don't have time for all that, and you're not going to be tested on all that. So it's there for your enjoyment. Intrinsic control, again, through the nervous tissue within the heart. You've got the pacemaker, is the SA node. What does that stand for? The sinoatrial node. Okay. The AV node delays the impulse to contract from the SA node by approximately 1/10 of a second. So the ventricles contract after the atrium. We wouldn't want them contracting at the same time. We need that loved up. Extrinsic control, parasympathetic nervous system, which innervates both the SA and AV nodes, arises from the medulla via the vagus nerve. The release of acetylcholine, decreasing activity, increased parasympathetic activity. If you increase parasympathetic, it will slow things down, brings your heart rate down. Okay? If you decrease that parasympathetic activity, things are going to get increased. Okay? So this is where if someone has a problem with a nerve, you can see, with the vagus nerve especially, you're going to see some problems with their heart rate. You'll see either go way low or way high. The sympathetic nervous system, this is the fight or flight. It's going to release norepinephrine, increasing the activity. So once you start, if you're walking down the street and someone comes up behind you and tries to rob you, and they stick a gun at your back, you're going to have this release, okay? Norepinephrine, which will increase everything. You're going to start sweating. Your heart rate's going to go. All that stuff that happens is a result of the sympathetic nervous system. Okay? This will also increase the force of the contraction to get blood flowing quicker, more powerful. So remember, parasympathetic slows things down, sympathetic speeds things up. Endocrine system, again, all kinds of different glands and so forth. Epinephrine by the adrenal gland. Again, stimulated by that sympathetic nervous system. And again, your heart rate is a result of the balance between these. We have an equilibrium. We each have a resting heart rate. Okay? That can be adjusted with training or detraining. But for the most part, we have a homeostasis between these two. If you don't have that, you can get increased heart rate or decreased heart rate due to the hormonal changes. Extrinsic control. This is the schematic showing you the influence there. All right, so cardiac muscle, completely different than skeletal muscle. Cardiac muscle has these intercalated discs which propagate the electrical charge through them. Do not have that capability in our skeletal muscle, okay? Obviously, very high mitochondrial density. These are powerful cells, okay? They have to be. Great big capillary network. Again, efficient use of aerobic energy system. What is aerobic energy system? What does that mean? It uses oxygen. So you have to have oxygen for the cardiac muscle to exist, okay? If you deprive it of oxygen, what's going to happen? Same thing we talked about just a few minutes ago. Myocardial infarction. If you cut off the blood supply, which carries oxygen to the tissue is going to die. When that tissue dies, that's when you have a heart attack, okay? Medical abbreviation for that is MI. You will see that in charts. Again, the thicker the wall of the chamber, the greater the force of the contraction. The left ventricle has the greatest thickness. Physical training can increase that. So folks who are long distance runners, exercise at altitude, things like that, that need tremendous amounts of blood flow, have a thicker walled heart on the left. Now, that can be problematic if it gets too thick, okay? Again, I can't tell you what's too thick and what's not, but I know that what is it called? Cardiomegaly is an enlarged heart, can be an issue. You get electrical issues with that. People with Marfan syndrome, anybody know Marfan syndrome? super tall, long extremities and so forth. There was Flo Hyman was a gold medal volleyball player. I think she was like 6'6". Died instantly of Marfan syndrome. Her heart basically just gives way because it gets too thick. So if you see somebody, you guys talked about that in pathology? Marfan's? Okay. All right, important slide here. CO equals the amount of blood pumped per minute. What does CO stand for? Cardiac output. Okay? This is determined by heart rate and stroke volume. I know how much y'all love math. Right here under amortization. Heart rate times stroke volume equals cardiac output. Make sure you understand that concept. Don't just memorize it, okay? So for the normal untrained individual, a male with 72 beats per minute and pumps 70 milliliters per stroke will yield 5 liters per minute. The heart will pump 5 liters per minute.
So the stroke volume is every contraction.
What's that now?
The stroke volume is every contraction?
Yes, yes. Every contraction that your heart produces, how much blood leaves it. That's stroke volume.
And then cardiac output is just over a minute.
That's over the time, how much does it do? Okay. In trained subjects, heart rate at rest is lower and stroke volume is higher. Very important concept. When we train cardiovascularly, not just weightlifting and so forth, if this will go up, stroke volume. Your heart becomes more efficient. When it pumps more. If this is more, this can be less. Yield the same cardiac output. Okay? That's how your body accommodates to training. That's what we're talking about in this course. So make sure to understand that. And conversely, with detraining, if you've got somebody who's been bedridden for X number of time, their stroke volume is going to go down. Therefore, their resting heart rate is going to have to go up to maintain the same cardiac output. Yes, sir?
So is it going to be, the stroke volume going to be more or less within aerobic? Like people who do a lot of endurance training and stuff like that compared to cardiovascular?
Stroke volume will go up with that.
With aerobic?
Yes.
Okay.
Yes. Again, what influences stroke volume? The amount of blood in the ventricles before contractions. Shoot, I meant to bring. So a water balloon. Okay, imagine a water balloon that's half filled. If you squeeze it, only so much can come out, right? If it's all the way filled and you squeeze it, you've got a lot more capability. So again, you've got to be able to fill. The blood, the ventricles everything has to be efficient. Okay? So if you have leakage in the valves and you get backflow, so that ventricle contracts and that blood should shoot up through the aorta, but some of it goes backward because your valve doesn't work right, not as efficient. Not as efficient. So therefore, your stroke volume is going to be less and your heart rate is going to be higher. Are we seeing how all this kind of ties together? Yes, sir?
Is that going to happen with pre-ventricular contractions?
Yes. If you've got timing issues, that ventricle is not going to fill completely. And if it doesn't fill completely, you can't pump it out if it's not in there, right? So I was saying about the water balloon. If you got one that's only half full and you squeeze it, only so much can come out, okay? We want that filling, all right? So, the concept of end-diastolic volume, the amount of blood in the ventricles before the contraction, okay? versus in systolic, which is the amount of blood in the ventricles after contraction. That is what stroke volume equals, okay? So we can now take this equation and put this in here. That's synonymous. So we can see now how either one of these factors can greatly affect cardiac output. Again, it's math. It's math. We have to learn this. If end diastolic volume increases and end systolic volume remains the same, stroke volume increases. So again, fill the balloon and squeeze it. More's coming out. So during exercise, venous blood return to the heart increases. We're more efficient. So veins have valves in them, okay? Especially down in our legs and so forth. When we talk about DVTs and stuff like that, pumping, doing ankle pumps and things like that helps to pump blood back up to our heart. So as muscles contract, especially in the lower half, blood gets back at a more efficient rate. We want that. That's a good thing. What happens if your valves don't work? Pooling, I heard somebody say, right? What ends up happening with blood pooling? Anybody know? Venous insufficiency is the actual term that it is. But what does it look like? What is it going to look like if you see a patient with this? You look at a chart and you see somebody's got venous insufficiency. What does that look like? They've got weird discoloration. It's usually going to be darker. They're going to have swelling in both extremities for the most part. It's not going to be one side, it's going to be global. Okay? Because of the inability to get that. It may not be completely unable, but it's not as efficient. Yeah?
They'll go pulseless in that area.
They will be pulseless in that area, or decreased pulse. Yes. Yeah. So if you've got somebody like that, you probably all have somebody in mind with that, if you're working with geriatrics at all, that has swelling in bilateral lower extremities. Okay? That might be lymphedema, it might be venous insufficiency, it might be both. So you gotta think of those things. Is that somebody that you can exercise rigorously? Probably not. Probably not. Is that somebody that would benefit from, say, like compression stockings? Absolutely. Would they benefit from elevating their legs in bed? Absolutely. So these are things that we can help them with. Okay? Increases in diastolic volume stretches ventricles slightly, just like the balloon we talked about. The elasticity of our tissue. Blood comes into that ventricle and it stretches it a little bit more, it's going to have a better capability of compressing and injecting that blood. Okay? We need that. We need that little bit of stretch to really maximize everything. Again, we talked about the sympathetic stimulation, increasing everything in the strength of contraction. Don't forget that. Sympathetic response. What's an example of a sympathetic response? No. I'm talking about physiologically. What happens? What triggers that increase in the heart rate and increase in the contraction? That's right. The release of the hormones. Norepinephrine, epinephrine, all the others as well. There's a bunch of them out there that are ones that are going to increase that heart rate and increase the contractility. Sympathetic hormones. Blood pressure. Obviously important. We talked a lot about that. The term afterload, the mean blood pressure in the aorta. So if blood pressure, so what is blood pressure? Think about that.
It's the force at which blood's being pushed
How
out.
much force is being pushed on the outer walls of those vessels, right? Is that a good thing to have high blood pressure or a bad thing to have high blood pressure? Everybody's gonna say bad, but we have to have some blood pressure, right? If you don't have a certain level, you're gonna be really, really lethargic. My mother-in-law has very low blood pressure. She gets really fainty very, very easily, okay? Same one that can't stand up that's written here. But if you have high blood pressure and high blood pressure all the time, do we want high blood pressure when we're exercising?
Sideways.
It depends. It depends. If we have weakened vessels, we don't, because that's how problems occur. Strokes, etc.
But you have to have higher pressure to get it everywhere.
But you have to have higher pressure to get it circulating. That's right. So we want high pressure when we're exercising, but we also want strong vessels as well. So what weakens the vessels? Disease. What disease?
Stenosis.
You guys know the two terms. Arterial sclerosis and atherosclerosis. What's the difference?
Heart is hard, so arteriosclerosis is the hard one.
Art versus at.
Math is bad.
If you want, just put an F in front of this one, because this is fatty tissue within the vessel. That's not a good thing, right? And this one is hardening. Arterial sclerosis versus atherosclerosis. Neither one is a good thing by any means. But that's how we affect laminar flow. If you get a clot, it can be attributed especially to the atherosclerosis. All right, ejection fraction. I had a, so the funny thing about this, I giggle when I think about this. My cardiopulmonary teacher, who wrote the textbook, so he wrote a textbook before he came to PT school. He was an exercise physiologist. Super brilliant guy. But he was in the PT class ahead of me, just one class ahead of me, and he had written a textbook. So the textbook that we used for cardiopulmonary was written by this guy, but he was a student because he was going back to get his PT. So now he's a dean at University of Montana, where I got my doctorate. Anyway, he would always say, no one can pronounce this right. Everybody will say ejection fracture. So please don't do that. It just made me laugh when I was thinking about him. He was a really funny dude. Ejection fraction is the amount of blood available to be pumped by the ventricle in diastolic volume to the amount of blood that is actually pumped out. So, if we take that balloon, we know how much is in there. That's our in diastolic volume. And then out, actually, how much when we squeeze it comes out? Not all of it's going to come out. That ratio is our ejection fraction. So EF equals EDV divided by stroke volume. And it will be in a percentage.
Is this what they look at when they're looking at backflow?
Yes. Backflow would negatively impact this. Yes. Yes.
Are there a lot of like these equation type of questions in there?
I wouldn't say there's a lot, but there's going to be one or two. So if you're comfortable missing one or two, you can just ignore this. But you're probably going to miss them on the final exam too, so that's fine. Hey, it was funny, when I was in PT school and we started talking about neuro stuff, my teacher actually told me that. She's like, you don't get this. I said, no, I don't. She goes, cut your losses here. She goes, you're really, really good in orthopedics. This is when we talk about board exam. She goes, you're gonna know 90 to 95% of the stuff in the orthopedic part. She goes, that means you only gotta know about 60% of the neuro. So learn 60% of the neuro. I knew 60%, but that was about it. But I did get the neuro question today correct, by the way. Anybody look at PTA 365 today? You might see some of these. Hey, you might see some of these questions. I will pull some of these from time and put them on file. Anyway, ejection fraction. We're looking for a normal range of 55 to 70%. So if we have somebody who is so deficient, that's where their numbers are going to lie. And we're not worried about it if it's above that, great, awesome. When we start getting down here into this lower, below 50%, what do you think that's going to look like? Get tired very quickly. Yes. There you go. There you go.
We got her up from walk. I think she probably walked out the room and came back because she was like she was too tired to do anything.
So as a clinician, we have to know that. We have to know that. Because if we don't know that, was that in our chart, I assume? So if you don't know that, and you see somebody who's just can't walk, well, what else could it be? It could be a whole host of other things. It could be a neurological problem. It could be endless amounts of things it could be. But if we know this in advance, we know we're going to get that. So therefore, you shorten the things that you do. You work in shorter increments with longer rest periods and so forth. Does this make sense? I know it's math, but it has to make sense to you, okay? So ejection fraction is a really good measure of efficiency of the heart. Is it efficient? We know it's pumping, but is it pumping right? Anybody in here know anything about HVAC units and stuff? A little bit? We want to know how to cool a house. We know that air is getting it where it needs to be, but we need it to be efficient too, because we don't want our bill going through the roof, right? All right. If we increase our ventricular function, our ejection fraction is going to go up. Therefore, if it's decreased, if we're not pumping, we're not squeezing, it's not getting out, our ejection fraction is going to go down. One reason for the decrease of all other variables remaining the same is increased blood pressure. Okay? Training results in a decrease in blood pressure, decreasing the work of the heart. Training may also increase the volume of the ventricles, increasing stroke volume. So, basically what we're trying to say here is, with training, heart rate can go down, or heart rate will go down, stroke volume will go up, and ejection fraction should get more efficient. We should see improvement here with training. Okay? Now, what kind of training is that? Is that lifting weights? Is that stretching? Is that working on coordination? Sorry. No, it's aerobic training. So we've got to get our heart rate up to a certain level. We'll talk about how we do that in a minute. Ventricular EDV increases at rest during physical activity, increasing stroke volume. Think about that. We exercise, and then we rest, our heart can fill back up, right? Those ventricles can expand, and then, again, it's a muscle. It has to contract to eject. How does volume increase? Increased plasma volume. What's plasma? If you take the blood cells out of your blood, if you spin your blood and you see the top part's the dark part, the bottom part's the clear part, that's plasma. Plasma is made up of 91% what? Water. So we need to stay hydrated, okay? If we increase contractility, that will lower our end systolic volume. In moderately aerobically trained subjects, stroke volume increased up to 40 to 50% of peak O2 consumption. Okay. Again, that doesn't tell us a whole lot. It doesn't tell us how they train, how long they train, all that kind of thing. Heart rate has a linear relationship to maximal workloads. Okay. That makes sense. If we work more, our heart rate has to go up. Do you agree with that? Okay. After strength training, resting ventricular EDV changes very little because we can't exercise our heart like we can our biceps. It doesn't work that way. Okay. We stress our heart by doing aerobic activity, not concentric and eccentric activity. Okay. Now, if you do strength training with interval training, we all know what that is, right? So we're doing short bursts of work, intense work with a little bit of rest, and then alternating that. That can help. Huh?
Like HIIT workout?
Yeah, like a HIIT workout. Yep. Everybody know what a HIIT workout is? High intensity interval training. We'll do one of those today. Somebody in that cup will do. Don't eat much lunch today.
Worried a lot.
You signed a release form, so. I keep saying it. Did y'all really sign it? You don't remember that? We did so much in orientation, y'all don't have any idea what you did.
We were like,
Obviously,
just
blood
thinking
pressure is
about
not
it.
important. We got a blank slide. Laws governing blood flow. Low blood flows from high to low. That's just like anything else in life. The rate of flow is proportional to the pressure difference between the two ends of the vessel or the two chambers. Increased flow, we increase the pressure, decrease resistance to flow. What is resistance to flow? Give me an example of resistance to flow.
The angle, like gravity.
Gravity can certainly impact that. It's going to be harder if you've got swelling in your lower extremities to get it back up up into here, right?
With the viscosity of it,
What does viscosity mean?
how thick.
How thick your blood is. So we talked about plasma earlier. If you're dehydrated, is your viscosity increased? That's correct. Therefore, if you are dehydrated and your viscosity increases, then your resistance to flow increases. It's thicker, okay? Harder to pump. What else? What else can impede this resistance to flow? Absolutely. Huge. If you've got fat in your blood and inside your arteries, how many of y'all been down Chattahoochee in some type of boat, vessel, something or other, canoe, whatever? When it gets narrow, if you think of fat on the sides of an artery, think of the narrowing of the Chattahoochee. It gets a little quicker, doesn't it? But if you go out here where it's nice and wide and there's no resistance, just a smooth flow. But you get it narrow, it's gonna speed up, okay? And same thing, you were talking about gravity and all that stuff too. Makes a big difference. We all right with this? The other thing too, arteriosclerosis. If the vessel is hard and doesn't comply, okay, we don't have the ability to expand or contract, that can influence the resistance as well, mostly in a negative manner. Because we need those vessels to have that extensibility. You guys remember studying about the, oh my gosh, let me think about this, tunica adventitia of the makeup of vessels and so forth? Because they have the ability to expand. We need that. And if they're hard and they don't expand, it's going to be problematic. Because increased pressure comes and it can't expand, what's going to happen? It's going to fail somewhere. Yep, you're going to have an aneurysm, you're going to have a stroke, you're going to have a heart attack. Laws governing blood flow. Love laws. Black and white. Blood flow, change in pressure, resistance to flow. Yep, easy. Resistance is inversely proportional to changes. Twofold increase in pressure equals a twofold increase in flow, okay? Good with that. Twofold increase in resistance decreases flow by 1/2. So, if we've got our artery, and it's this big around, and then we've got fat that takes half of it away, so now the actual flow part of the artery is this big, that's going to be what? Decreased flow by 1/2. Things are going to smooth down. But then your pressure gets higher, right? Because of that. Well, it's still got to get through there. That's where all of these things combined with high blood pressure, diabetes, all that stuff, comorbidity, you're going to see it over and over. You're going to see it over and over if you already haven't seen it. All right, let's see. Viscosity, we talked about already. Radius of the vessel, reducing the radius by 1/2, increasing the resistance 16-fold. Wow. Reducing radius. Increases resistance 16. I'm trying to think of an example with that. Use the atherosclerosis. I guess when you're going from arteries down to arterioles to capillaries and so forth, but as you're getting further away from your heart, the pressure actually decreases. So I have to think about that one. Blood flow is controlled by simultaneously controlling changes in pressure and resistance to flow. That's what we've been talking about the whole time. Changing the radius of major way blood flow is controlled at rest and during exercise. Again, extensibility of the vessel. And this is what we were talking about just a second ago. Blood pressure typically 120/80 in the brachial artery. That's where we take it, right? Is the blood pressure going to be the same if you take it in somebody's foot or ankle? Nope. It's going to be higher or lower? It's going to be lower. Just because of the distance from the heart. Okay. Pressures in the left ventricle are the highest. That's the source of the pressure. With decreasing vessel size and length, increasing resistance to flow, blood pressure decreases. We get further away. We get further away into those capillary beds and so forth. That pressure is going to decrease. The greatest pressure decrease occurs in the capillaries. There's also very low pressures in the venous system. So there's not enough pressure. That's the person with venous insufficiency. Not enough pressure to get things back. They don't have the valves working right. There's all kinds of things. And again, think about this. I heard this a long time ago, and it's very true. Wherever you see blood, there will be swelling. Okay, because especially if that blood pools and it doesn't go anywhere, it's gonna leak out of the vessels. That plasma, that's what ends up resulting in the edema that you see on so many of these people. Blood pooling will eventually cause edema. Pressure is increased with increased cardiac output. That's obvious. Increases during exercise, partially offset by vessel compliance. That's the ability, again, if you have hard arteries, they can't comply. Compliance is increased with training. So we can make our vessels more compliant by working them out. Okay, they don't get harder as a result. They get more flexible. Mean arterial pressure, average pressure driving blood through vessels equals diastolic pressure plus 1/3 of difference. All right. I have to really think about this concept. This doesn't come natural to me. So if the diastolic pressure is normally 80 plus 1/3 the difference between, okay, mean arterial pressure. Okay, so it's trying to average it out. I get that now. You see that concept? Mean arterial pressure? How do you come up with that? Diastolic pressure plus 1/3 the difference between systolic and diastolic, which is usually, again, on average 120 over 80. So 1/3 of that 40, add that to 80, comes 93.2. I have seen mean arterial pressure questions on the exam. I always missed them because I didn't really understand the concept. I would definitely know that formula. Oxygen delivery, which is this whole thing. Depends on two factors: the amount of oxygen tissue takes out of the system, and the amount of blood through the tissue. So we've got to have efficiency at the lungs to get the oxygen that we need, and then we've got to transport it through the blood flow. Okay? It sounds like a pretty simple system, but really super complex. Lots of factors influence it. At rest, both remain constant given the type of tissue. During exercise, both O2 and the amount of blood through increase because the demand increases. Okay? If you are exercising, your brain, your legs, your gastrocnemius, your glutes, all those need more oxygen. So we get that through an increase in the cardiovascular system. Increased flow, increased pressure. Oxygen difference. Between the amount of oxygen in 100 milliliters of blood in a tissue and out leaving the tissue. I don't think I've ever seen one of these questions on there. This is more exercise phys than I think it is PTA exam. Don't worry about that one.
How much did you say the board is cardiac?
I'm sorry?
How much of the board is cardiovascular?
30.
30%.
30 to 35%. A lot. But again, you see how this is influenced by pathology, by exercise. I mean, there's so much crossover between all this. So don't feel like, oh my gosh, we're going to cover this in 3 days and it's 30%. That's really not the case. So at rest, 15 to 20% of our cardiac output goes to skeletal muscle. But look at this. If you're exercising at a max level, 80 to 85% of cardiac output goes to skeletal muscle. We've got to feed them. Therefore, this is why your mom said, don't eat and then go swimming. Because when you eat, what happens? You get increased blood flow to your GI tract to help with that digestion and motility. So if you do that, you eat a big thing and then you go swimming or running or whatever, not only is it not going to feel good here, it's probably not going to feel very good. You're not going to perform very well because you're not going to be able to get the needed 80 to 85% of cardiac output to that skeletal muscle because it's already busy. Anybody's mom said that? My mom always said that. Don't eat and then go swimming. I don't know why it didn't apply to running or anything else. It was always swimming.
She'll see the dinner to drink.
If you would know.
That's why Western says that.
You think that's what it is? Is that anything to do with physiology?
I don't think.
They're not thinking about that?
People know about physiology enough. They just say if you eat and swim, you'll grow up, and if you grow up in the pool, you'll
Evacuates. It's a problem for everyone. Yep. Good point.
Sam would know.
Actually, Sam, my mom explained that 80 to 85%.
She did?
She did? All right, y'all take 8-minute break. Be back.